and welcome to the ACR Journals on Air podcast. I am your host, Vicky Shamagam. Interstitial lung disease often develops within 3 to 5 years of the first non-Raynaud's symptom in systemic sclerosis. And so most patients are screened at presentation and for the first few years after diagnosis. Clinical trials often limit inclusion only to patients with a certain number of years since the first non-Raynaud's symptom. But have you ever seen patients who develop interstitial lung disease later, after 5 or more years of disease? The manuscript we will discuss today is Characterization of Incident Interstitial Lung Disease in Late Systemic Sclerosis. It was published in Arthritis and Rheumatology, and a link to the manuscript and disclosures can be found in our show notes from today. I'm so happy to be joined today by Dr. Sabrina Hoa and Dr. Marie Hudson to discuss their work investigating incident interstitial lung disease in scleroderma. Dr. Hoa is a rheumatologist, associate professor, and researcher at the University of Montreal. She holds the University of Montreal Scleroderma Research Chair and co-directs the Canadian Scleroderma Research Group. Her research is focused on studying the impact of early detection and treatment of scleroderma complications, with a particular interest in interstitial lung disease. Dr. Marie Hudson is a rheumatologist, epidemiologist, and associate professor in the Department of Medicine at McGill University. She's a physician scientist and member of the Center for Clinical Epidemiology and Community Studies at the Lady Davis Institute for Medical Research at Jewish General Hospital in Montreal. She has particular interest in systemic sclerosis and autoimmune myositis, as well as immune-mediated adverse events from cancer immunotherapy, which she studies as a human model for classical autoimmune diseases. Bonjour and welcome to the show, Sabrina and Marie.
Bonjour, Vicky, and very nice to meet you.
Bonjour.
So, Sabrina, I'm going to start with you. We know interstitial lung disease is one of the deadliest complications of scleroderma, and we're taught to screen all patients for this complication early in the disease. But we're also taught that after about 5 years, the risk drops significantly. What were you seeing in your clinic that made you want to investigate late-onset lung involvement in scleroderma?
So thank you for this question. So yes, in clinic, I was seeing some cases with late onset ILD, and I think Marie was seeing some too, although not so many, maybe because we're not looking for it actively. But if your question is on how this project was born, it was actually following a journal club discussion during which we were discussing new screening guidelines, which, as you know, recommend that all patients with scleroderma be screened with an HRCT at baseline. But then some of my colleagues asked me, well, what about my patients that I've been following for 5, 10, 15 years and who haven't developed ILD, but who had never had a baseline HRCT because this was just not standard of care back then? Should I order a baseline HRCT in those patients, even in the anti-centromere positive patients? And to those questions, I said, well, I don't know. And that's how the project was born, to better understand how frequently late onset ILD occurs in scleroderma, if it's similar or different to what we see in early disease, and if it should be treated the same, and who would be at risk of developing late ILD and need monitoring or surveillance for this.
Oh, it's brilliant. I love research studies that begin with I don't know. I feel like you get the best results from those. So you use the Canadian Scleroderma Research Group registry for this work. Tell our listeners about this registry, who's enrolled, and how are they followed up?
So the Canadian Scleroderma Research Group registry is a multicentric cohort study that has been recruiting patients with scleroderma since 2004, with over 1,700 participants enrolled to date. Patients are followed once a year, and at this annual visit, there's detailed information on their disease, their symptoms, and the investigations that they had over the past year. And all of this is entered into a database. And we also collect serum at these annual visits, which is biobanked centrally.
And in this manuscript, you only investigated the patients who didn't have ILD at cohort entry, so no prevalent interstitial lung disease. And the outcome you were studying was the development of incident interstitial lung disease. Was this a convenience study, or did the people enrolled have regular follow-up scans and pulmonary function studies as part of a protocol?
So because the CSRG is an observational study, there are no regular annual scans or pulmonary function studies that are planned as part of the protocol. So patients will get these exams as clinically indicated in their care. So we recognize that because not all patients had a screening HRCT at cohort baseline, the study may have included people with prevalent subclinical ILD, and so results should be interpreted as characterizing the incidence of clinically apparent ILD. And we did perform some sensitivity analysis limited to participants with a negative baseline HRCT, which yielded results that were generally consistent with our main findings.
And Marie, I'm going to loop you in now with your epidemiologist hat on. The question that Sabrina wanted to study couldn't really be answered without a study like this. But observational data sets have some limitations. What are the pros and cons, and how can you best use observational data sets in research?
So great question. So two things. First of all, there are some questions that can only be answered using observational designs. And a very simple example of that is smoking. You wouldn't be able to randomize people to smoke or not to smoke to study the health effects of smoking. So yes, there are potential confounders, but there are some questions that can't be answered otherwise. But the value of this particular study and the observational design, I think, is in the idea that this is hypothesis generating. So there was a question, we generate some data to get closer to an answer, but we know that answer is far from perfect. But in turn, this provides the rationale then to perhaps go on to a randomized trial. And I'll give you a very simple example for that. One of the first projects that Sabrina did with me was actually looking at mild ILD. So people, scleroderma patients who had interstitial lung disease, but who had FVCs above 80%. Using the same data set that she used here, she was able to show that patients who were started on immunosuppression early, not for the ILD, but for things like arthritis, myositis, skin disease, then at 1 and 2 years, their lung function was preserved compared to patients who were not on immunosuppression. So what did she do with this study? As I said, it was a hypothesis generating study. She turned around, and right now she's actually conducting a randomized trial looking at if you randomize patients with mild interstitial lung disease to some immunosuppression up front, even when the FVC is normal versus not, can you preserve lung function? So I think the value of observational research in this setting is to help us move towards answers, sometimes answers that cannot be obtained through randomized trials, but sometimes to justify going on to a randomized trial.
Great advice. And so how many people, Sabrina, in this study without incident ILD at baseline developed ILD during follow-up? And what did you find when you evaluated the timing of this complication?
So about 20% of patients developed ILD over about 1 to 4 years of follow-up. And interestingly, we found that, yes, people can develop ILD later in disease. The incidence rate of ILD among people over 7 years of disease duration from their first non-renal manifestation was 3.7 per 100 person years, whereas in earlier disease, it was 5.4 per 100 person years. So the risk of developing ILD was lower among people with late disease compared to earlier disease, which is consistent with previous studies, but it shows that it can develop later.
Great. So you proved the textbooks wrong. I love it. When you looked at the patients with early onset ILD compared to those with late onset ILD, did you see any differences in demographics or other clinical characteristics or autoantibodies that should prompt us to be thinking more closely about this?
So we found that risk factors to develop ILD were very similar between early and late onset ILD. So for example, male sex, ethnicities other than white, presence of diffuse skin involvement, myositis, high CRP levels, anti-topoisomerase 1 antibodies. These were all associated with a higher risk of ILD, whereas anti-centromere antibodies were associated with a lower risk. So all of these risk factors are very consistent with what is known in the literature. But something novel that we found was that anti-RNA polymerase III antibodies and the presence of arthritis were two risk factors that were more unique to late onset ILD. And finally, we also found that the severity of ILD, as measured by FVC and DLCO, was quite comparable between the two disease duration groups.
Oh, that's really important. So Marie, on table 2, you present some data from some complex analyses adjusted for disease duration and stratified by late and earlier disease stages. Why was it important to do this analysis, and what did it show?
Okay, so thanks for the question. And I'm going to try to walk you through table 2 because I agree that it is somewhat complex. So the simple question we were asking in table 2 is, what are the risk factors for developing ILD? So what are the features of a patient who's going to be sitting across from you that might make you think that this patient might be at higher risk, yes or no, to develop lung disease? But the question we're asking has a special twist to it. And the twist is, what are the risk factors, and are those risk factors the same or different depending on disease duration? So there are two complementary ways, if you want, to try to answer that question, to see if there are differences between subgroups. We can either do interaction terms or we can do stratified analysis. The statisticians love interaction terms. It's a sort of a tool precisely to look at differences between subgroups, but interaction terms are sometimes quite hard to interpret. And even for myself, sometimes I have a hard time wrapping my head around that. And so we thought for the reader, perhaps more straightforward way of presenting the data was to simply stratify the data. So if I give you 2 examples from table 2, if you look at diffuse disease, so the first question in the model with the interaction term, the question is diffuse disease a risk factor for ILD? And does this differ between disease duration? So clearly with a hazard ratio, or this was an odds ratio, of 1.74, diffuse disease is a risk factor. But because the p-value for the interaction term is close to 1, what that means is diffuse disease is probably a risk factor both in early and late onset ILD, because that interaction term is not significant. However, and then we tested that again using the stratified analysis, and that's exactly the same answer that we get. We stratified by early disease and late disease, and we saw that diffuse disease was a risk factor in both subsets. So here, the 2 models are consistent. And often, I say in statistics, there are different ways of analyzing the data. Sometimes they don't necessarily give you exactly the same answer, but provided that they all point in the same direction, that's actually a reassuring thing to say that the data that you have or you're presenting is quite robust. If we look down at table 2 at the RNA Pol3, and Sabrina just alluded to the fact that maybe there's something going on with the RNA Pol3 antibodies that is different by disease duration. So in the model with the interaction term, RNA Pol3 seemed to be a risk factor for ILD. With the p-value for the interaction, there was a trend to suggest, the p-value is 0.1, the trend suggesting that, maybe, yes, it's a risk factor, but maybe this risk factor is different according to disease duration. So there, the stratified model can be very, very helpful. So we simply stratified the data. And that's what Sabrina was alluding to. In early ILD, RNA Pol3 does not seem to be a risk factor, as would be, for example, anti-topo. Whereas in late ILD, anti-RNA Pol3 does appear to be a risk factor for ILD. So that's really important. As Sabrina was saying, her colleagues were asking her, should I do a CT in somebody with long-standing disease? Well, if your patient has diffuse disease and an RNA Pol3, these are the sorts of clues that will help us make these clinical decisions.
I love that. That's really helpful advice and information that is very practical for use in the clinic. So thank you for sharing that. Sabrina, figure 1 shows a Kaplan-Meier curve, and I love a visual in a manuscript, but I'm going to make you describe it. It's looking at ILD progression in the early onset compared to the late onset ILD groups. Did you see a difference in how the patients who developed incident ILD subsequently progressed with disease based on the timing of onset?
So interestingly, note the curves were quite overlapping, and there was no significant difference in the progression rates between late and early onset ILD. Progression occurred in nearly half of patients, and mostly within the first 4 years of ILD diagnosis. So what this is telling me is that it is equally important to detect late and early ILD because both can be at similar risk of progressing to more severe disease.
Yeah, again, incredibly helpful tip that will be useful to all of our clinical rheumatologists. And I really appreciate that you did this study because we didn't know that. And so it's useful to know. So in any retrospective observational study, patients are treated, as you'd mentioned, according to standard of care, and this study was no exception. The patients enrolled in this study were on a variety of immunosuppressive agents. Did you see any differences in people who received immunosuppression?
So ILD patients who received immunosuppression had lower FVCs and DLCOs, which are known risk factors for ILD and are probably the reasons why treatment was initiated. And interestingly, on exploratory analysis, we noted that immunosuppression was associated with a numerically lower risk of lung disease progression in early onset ILD, but not in late onset ILD. So I'm not sure what this means, but it's just an interesting observation that needs to be explored further.
Yeah, and one wonders, is part of this a confounder of just not treating that group so aggressively, I wonder.
Yes.
So this is fascinating, and I kind of want to know, what does this mean for practicing rheumatologists? Marie, should we be screening patients for ILD more consistently late in disease?
Hmm. So that's a thorny question. I think the word screening means means a lot of different things to different people. I will say that what this data suggests is, first of all, I think we need to continue to follow our patients. I often have patients who have come to me saying, "Oh, my previous rheumatologist said there was nothing to do and just not to come back," and I completely disagree. That was perhaps several years ago, when it's true we didn't have a lot of treatment options. Now we have a lot more treatment options, and a lot more are coming as well. So I think the onus is on us to follow our patients and screen them to begin with a good history and a physical exam. That's the first thing that we have to do, at least on a yearly basis, and really dig hard on that history to try to understand if they've developed symptoms compared to the year before. If they've stopped exercising, why did they stop exercising? Was it for breathlessness? And then, so you sort of have to push the patients to get the relevant information. The second thing that I routinely do at a minimum annual PFTs. I've been doing that for years, mostly for pulmonary arterial hypertension screening. But I think that my annual PFTs now are going to come in really handy, because I'm also going to have an annual FVC. So until we look at the screening question more carefully and who should benefit from a systematic high-res CT, because that might be the next question, should we be doing a CT? I think at a minimum, we need to see our patients, we need to examine our patients. I think PFTs are very useful tests to do, and non-invasive, and that's at least a start. And then based on that, of course, if the patient has symptoms or new symptoms, then I think, and then in that setting, if I ask for a CT, I don't even call that a screening CT. I call that a diagnostic CT. So that's my approach at this point towards patients who, as Sabrina mentioned, who have not had that baseline high-res CT. If they are anti-centromere positive, they've been stable for years, their skin hasn't evolved, they don't have any new symptoms. To be honest, I'm not doing a high-res CT to detect ILD unless they have new symptoms or physical findings.
Yeah, that's really good advice, and look forward to hearing a little bit more as the years go on, further epidemiology on this from your group. Sabrina, as we mentioned earlier, typically patients later in the course of disease are excluded from clinical trials. What's your opinion on trials specifically for this late onset ILD group? Do we need separate trials for that group? Do you think the enrollment criteria for ILD clinical trials should be broadened to include these late onset patients?
I think that given it's already very difficult to enroll patients in scleroderma trials, given the rarity of the condition, I would tend to go toward more broadening enrollment criteria to include late onset patients rather than designing specific trials for late onset ILD. But within these broader criteria, it would be really nice to have some subgroup analysis by disease duration so that we can get a better sense of drug efficacy within this late subgroup.
Yeah, I totally agree, and hope that the folks who design these trials start thinking about that. So I wanted to ask you both now a couple career-based questions, get a feel for some of the story behind your careers. Sabrina, how did you get interested in scleroderma, and what other areas of scleroderma research are you working on?
So I got interested when I was a rheumatology fellow. I saw that scleroderma, we know it's the rheumatic disease of the highest mortality. In our mortality and morbidity rounds, almost all the patients who had died were scleroderma patients. We know it's very morbid. There's no cure. So as a rheumatologist who cares for these patients and as a researcher, it was just natural to get interested in better understanding and trying to better outcomes in scleroderma. There's just so much work that needs to be done in this field. So my research program is mainly focused on better understanding how we could detect complications earlier and whether early treatments can make a difference in the course of disease, with the ultimate goal, of course, improving patients' survival and quality of life.
And you've worked closely with Marie and several other mentors over the years. What are your tips for a good mentor-mentee relationship?
I am so incredibly lucky to have Marie as a mentor. She has been my mentor since I graduated from rheumatology as a fellow, and then as a master's student, and even now as an investigator. And in retrospect, one of the things that I appreciated the most was that she believed in me since the very beginning, much more than I believed in myself. And she didn't hesitate to let me know. And that trust in my potential has been so, so precious because it gave me a lot of motivation and confidence at that early stage of my research career. And although I know that she is super, super busy, but she is always available to meet with me if I need it. And of course, this need has decreased with time, but I know that if I need to have a quick chat or just bounce off some ideas, that she will always be there and she will answer honestly and give all the feedback that she can. She has been just so generous of her time and knowledge over the years, and I could never thank her enough for this.
Oh, that's lovely. Marie, as the mentor, do you have an advice for junior rheumatologists or even senior rheumatologists on how to sustain the mentorship dyad?
Well, first of all, it's easy to mentor people like Sabrina. So I don't have any tips for mentoring talented and committed people like her. But having said that, I think two things. First of all, I think good mentorship means a lot of time. You have to put in time. If you agree to take on a trainee, a mentee, it their priorities have to be your priorities. They can't come after your priorities. So the time commitment is hard on the mentor, but is what allows the mentee to thrive, a little bit like Sabrina's describing here. The other thing that I would say as well, and I think Sabrina sort of just alluded to that as well, I think a good mentor at one point needs to know when to step aside and to let the mentee sort of fly on their own. And so in the last couple of years, Sabrina has taken on huge leadership activities with the Canadian Scleroderma Research Group, while I have been really pulling back and being less involved with that group. And it's amazing to see how well if you have the good foundation, then the mentee can really sort of take over and be and surpass the mentor, which is the sign of success.
Oh, I love that. And it's just so lovely to hear that you were able over the course of so many years to work together and in symphony together. It's just so beautiful to hear. So, Marie, if you're stepping back from some of those heavily involved roles in Canadian scleroderma, what else are you working on right now? And what gets you excited about the future of rheumatology?
Well, yes, I have lots of other projects ongoing. So if anybody listening has been involved with the Scleroderma Clinical Trials Consortium, you will know that I have been trying to develop classification criteria for renal crisis for now almost 10 years. We're almost done. I think we will have our classification criteria in the next year or so. We're doing the validation right now, and the data looks really good. So that will be a long-term project that will come to an end. The other thing that gets me very excited, and Sabrina knows this because I'm actually working with one of her colleagues right now, is the idea of scleromyositis, so the muscle disease in scleroderma, which I think has been really neglected for many years. And just to give you, if you can think of that graph that was put forth by Tom Metzger and Virginia Steen that people put up all the time in their presentations, showing the course of disease in diffuse disease versus the course of disease in limited scleroderma. Where's the muscle disease on that graph? Nobody's been talking about muscle disease. And I think we're making big strides in our understanding of muscle disease. And that is definitely something that will lead to novel insights into scleroderma altogether. And then the last thing, of course, and everybody is very keen on being involved with cellular therapies. I'm actually doing a randomized trial right now with mesenchymal stromal cells in severe scleroderma. The trial is progressing well. And we've just been funded to start an academic CAR-T program in Canada. And that too, I think, will be things that will help our patients. You know, it's one thing to do all the epidemiology and the descriptive work, but then we need to translate that into better patient outcomes. And I think the cell therapies is a really exciting direction for scleroderma at this time.
Oh, wow. So much coming down the pike. And I can't wait to have you back on the show to hear more about some of those therapies in the future. I want to really thank you both for joining us on the podcast today, for sharing your work. It's been a fascinating discussion, and I'm sure we're going to hear more from your group in the years to come.
Thank you so much, Vicky, for this opportunity to present our work.
Yes, thank you for having us.
And a shout out today also goes to rheumatologists who question what they're seeing at the bedside and why the research hasn't yet caught up. Thank you for helping us follow the biology and taking science where it needs to go. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow at AC Room on social media. Email us at podcast@rheumatology.org and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.